welcome everybody to the first webinar of the year for the Center for Multi-Stakeholder Demonstrations. I want to wish you all a big welcome from the co-chairs of this center. That's me, Sherry Erickson, with the American College of Physicians, Julie Schills, who's with the Colorado Beacon Consortium, Guy Mansudo, who's with FITEL, and Suna Kim, who just joined us as one of the co-chairs. She's from the American Academy of Pediatrics. So a big welcome from all of us. And I want to do a couple of reminders before we dive into the webinar. First of all, there will be a stakeholder meeting of the Patient-Centered Primary Care Collaborative on March 30th at the end of this month. You can go on to the pcpcc.net website to register for that. I understand it's actually filling up quite quickly, so it would be important to register as soon as you can. One thing I want to mention that there will be several things released at that stakeholder meeting and a lot of wonderful information shared through the presentations. One thing relevant for this particular webinar is that we'll be releasing a practice transformation guide that will include some case studies from a few practices in addition to a list of organizations that provide practice transformation types of services. And one of the practices that will be featured in a case study is Belmar Family Medicine, who's going to be presenting for us today. So this is a little preview of some of the information that will be shared in that guide. There are lots of other webinars going on for the PCPCC as well. You probably get quite a few emails about them. You can learn more about those on the pcpcc.net website. Specifically for this webinar, I want to note that it is being recorded, and it will be available on both the CMD section of the website or the media section of the website within a day or so after this webinar with the slides available. So you can download those or download the webinar itself to listen to it. And that will be available again within the next day or so. So you will be able to access any of this that you might miss or if you're not able to be on for the whole time. So. In terms of questions, one of the things, what we're going to do is our presenter will go first, and then following her presentation, during her presentation and following her presentation, you'll be able to type in questions onto your question bar. You can certainly type in any technical questions as we go, and our web administrator and others will answer those questions for you. But in terms of content questions for the webinar or for the presenter, we'll address those at the end of the webinar. And I'll go through and try to moderate and be sure I try to capture as many of the questions as possible, knowing that we may not be able to get through them all, but we'll do our best to get through as many as possible after she is finished speaking formally. So I'm very excited to introduce our presenter today from Belmar Family Medicine, Judy Hewitt, who is for the past 5 years has been the practice manager for Belmar Family Medicine, which is in Lakewood, Colorado. She's seen them through a multitude of transitions, finding and implementing an EMR system, bringing billing in-house, becoming an NCQA certified for diabetes and heart stroke, then later applying for and becoming a level 3 patient-centered medical home. She's also a certified instructor for a class on listening skills and has conducted numerous seminars on that topic. Prior to her experience at Belmar Family Medicine, she owned her own payroll and accounting business in the state of Oregon. In addition, she's traveled quite a bit all over the world, including to Mongolia. So she's got a lot of fascinating stories to share along those lines as well. So I look forward to Judy's presentation. She's going to be talking about a couple of different things, which she'll delve into. But overall, it's really about building the ideal patient-centered medical home team, including incorporating a care coordinator into that team. So we're really excited to hear this presentation. I'm actually going to kick it off with a little poll to that you all can respond to as Judy begins her presentation. I'm going to launch it right now, and then I'm going to ask Judy to go ahead and take over and begin your presentation. Thanks, Judy.
Thank you, Sherry. I really, really appreciate this invitation to speak today and to share what we have learned in our practice at Patient-Centered Medical Homes. I mean, at Belmar Family Medicine, we're doing, I don't know if you can see what's going on the screen here. We're getting this poll off of the screen. Oh, the poll has to be closed? Do we close it here? resume screen sharing. Can you hear us? We're trying to figure out how to get the poll. Okay, now we're back in business. So we have 38 that said yes, and 35 that are not currently patient-centered medical homes, and 27 that are working on it. So it looks like we have a pretty good mixture here. So now how do I get this back to the presentation screen? Okay, there we go. Okay, thank you, whoever took care of that. It wasn't me. Well, anyway, thank you so much for that introduction. You were blanked out for a couple of seconds through that, and I'm not sure what she said. Well, she had me on mute or something there. But anyway, we have been a patient-centered medical home level 3 for about 2 years now. And so what I put together to present today to you is what we have learned in that process. And we didn't realize what we were in for when we signed up to become a patient-centered medical home. We knew there would be a lot of changes, but there are so many things, there's no way to anticipate how it's going to affect your practice overall. But for the most part, it has been absolutely the most wonderful experience we've ever had. To start out with, let's say that there are 2 things that are required to be a successful patient-centered medical home. Anyone can be a medical home, but you have to really work on 2 areas to have a very successful medical home. And that first one is to choose the right care coordinator. And that was the focus of our presentation to start with. We expanded it to include building a team that works well together. But it's really hard to know how to choose a good care coordinator when you really don't really have an example of what a care coordinator should do. I know we got job descriptions and things, but back at the time that we became a patient-centered medical home, we were in the pilot group for our state, so there was no one else in our state that was already currently a medical home. So we looked at these job descriptions and we're trying to figure out what in the world we needed to come up with, how it was going to fit into our office flow and what was important to focus on. So that's what we're going to share with you. And also the other part of the presentation is how to have your team work well together, because when you have a team that's functioning well, you have excitement, you have people that are enjoying their work, as you can see with this exuberant group of workers here. So let's talk first about how to prepare to find a care coordinator. And the first thing you want to do is make your wish list. And I would make the wish list first before you try to do a job description. We had some sample job descriptions that we got, but they were very hard to interpret into reality, and it was hard to even picture some of the things they were talking about since it had never existed in our practice before. So the first thing is to make your wish list, and I'm going to talk specifically about each one of these as we go on to further slides. But so make the wish list and do a job description, and then there are several decisions that you'll have to make. One is who in your office can do the items on your wish list that you already have, and then who will do your interviews. In my article that I wrote, I talked about the fact that we actually hired a consultant for this care coordinator, and we started out with one care coordinator, and we're now on our second care coordinator. And from the things we learned from our mistakes with the first care coordinator, we have a much, much better fit now. But we hired a consultant, and that consultant was not just a general, generic consultant. This was someone who had connections with all of the patient-centered medical homes in our state, and possibly even with other states. But she was very intimately involved in the whole movement, and so she really understood. She had a real good understanding of what care coordinators should be able to do. And we made up our wish list and gave that to her. And with her background knowledge and with our wish list, she was able to find someone who was really a good fit for our practice. The other thing that you'll have to decide is, will the position be full-time or part-time? And that'll partly depend on how much of these things on your wish list can be done by existing employees and how much is going to require someone else to come in and do. And then what will the pay rate be? So these are some of the things that you'll have to do to prepare. So what needs to be on the wish list? When you have never had a care coordinator in your office, it's really hard to know what skills that person needs to have. It's almost impossible to find someone with experience unless you're in a state that already has patient-centered medical homes that have preceded you. In our state, there was no one with experience. So the best thing to make your wish list is to think about the programs that you want to run. So some of the programs that we run, and you may have other programs that you would put on this list, but I'll share with you what we have. We wanted to be able to run group visits for patients, our focused patients like diabetes and heart stroke. We wanted to have special group visits for them. We wanted this person to be able to be a public relations person, someone who's good up front, someone who's good to network, and who understands public relations in the media, such as marketing and your website, patient portal access, medical records and communication, and self-management programs were another thing that we have. We're developing some self-management programs in our office and actually had this consultant that helped us to help develop that program. That is a separate program. We found a lot of issues with trying to interject things like motivational interviewing and other aspects to the regular office visit. It just wasn't working. We tried it. We went to seminars that taught us how to do it, but the providers are so locked into a certain length of time for their visit that it was really hard to extend it and make extra things connected to it, and we were failing with that venture, and so we decided to come up with a totally separate program, a self-management program that patients would come in just special for, that was separate from their visit with the doctor. And there's a lot of issues around that we could talk about, but I don't want to get bogged down. So, and then another thing is building a medical neighborhood and the skills that are needed to be able to make that happen. So, and then the list of talents that we feel are needed, at least we felt we needed, was administrative skills. The person needs to be able to plan meetings. They need to be able to make agendas, do minutes after the meetings are over. They need to be able to maintain a calendar, and they definitely need to have reporting skills. They should be able to run the reports that you run every month, to submit to show what your measures, the progress that you're making on your measures, and then planning and creating self-management programs. And in our case, we'd already started planning, but she will need to continue working and making that a better program. And they need to have marketing skills, public speaking, public relations, data entry and registry maintenance skills, computer skills, and we decided that we would never hire anybody again as the care coordinator that didn't have a 4-year college degree. It was recommended at the time that we started that someone like an RN would be hired, but their pay rate is so much higher than what an MA is paid that we didn't see how we could afford to have someone at that pay rate in our office. And at that time, we didn't have the money to help pay any of the expenses because we were just starting. And then the personality needed. They need to be self-motivated. They need to believe in the cause. And they need to be energetic, charismatic. They should be a team player and a leader, visionary, and an extrovert. Now, that sounds like maybe it would be hard to find someone like this, but I think if you think outside of the box, that you will be able to come up with someone who has these skills. What we ended up doing was looking at someone who was not an RN and had never been a patient-centered medical home care coordinator before, but she was working on her master's degree in public health, and she also had some background in marketing, and she's absolutely the most charismatic and extrovert type person that I've seen in a long time. She definitely believes in our cause, and she has totally transformed our office since she took this position. The person that we had hired originally for this position was an MA, and So she did well with the registry, and she did well with a lot of the aspects, but most of the administrative skills and things were lacking, and that's what helped us to come up with this wish list. So if you don't make a really aggressive wish list, you won't get what you're looking for. But if you shoot for the stars, you'll get something that's really, really exciting. So, and I even put in here a few interviewing suggestions that can help to figure out if this person will be a good fit. What do you like best and least about your most recent jobs? That just helps you find out if they're positive thinking. Do they think about the best things first and the least later, or do they start out with the least things? What would your ideal dream job be? That's a good one to get an idea of what they're thinking of way down the road. What is it that they're headed for, so that you have an idea if this is going to be a satisfying experience for them. And how would you deal with an employee who argued against an idea you presented? That I would do as a role play to see how well they deal with employee issues and things that could come up in the office. It's since the care coordinator is a new position and is such an influential position, they really have to be a good team player to be able to get along with everyone else in the office. And some suggested tests, typing tests, ask them to present something at a staff meeting. That would give you an idea of how they present themselves in a public speaking situation. Ask them to make an appointment on their calendar and send it to you to make sure that they know how to use a calendar creator type software. Show me 3 marketing projects that you created so that you can see what their creative skills are. And ask them if they've done public presentations to show you a couple of presentations they've done so that you can confirm that they have actually done public speaking. And then after you hire them, you want to make sure that you can empower them. You want to give them the authority and the power that they need to be able to enlist the staff to work with them. You can't be intimidated by them being leaders in the office. You need to have them have that role. Set up weekly patient-centered medical home meetings and make sure that you introduce them to people, internal and external customers, your staff, as well as other people that come to the office. And include the care coordinators in your department meetings and staff meetings when you can, especially when it's appropriate to have them involved in programs that are related to their area of expertise. And then let the care coordinator fly. So that's kind of the part that's focused mostly on the care coordinator and choosing a care coordinator. So maybe, Sherry, if you're there, we should let people ask questions a little bit right here before I transition into the team building part, do you think?
I don't have any queued up at the moment. Oh, wait, well, here we are. Okay, sure. There's a question. I'm not understanding the care coordinator role. My assumption that it is about clinical care coordination. The role here sounds administrative.
Okay. Yes, I'm glad that they asked that, because that was what our assumption was that it would be clinical, and that's why it was suggested that you should hire an RN and that it was more involved with clinical aspects. But actually, you have your clinical staff already in place. You've got your providers, you have your MAs, and possibly you have RNs in your office, but we don't, but some practices that are larger might. And for us, how we decided to kind of divide it up is that all of the clinical pieces are run by existing staff. We are doing those things with our existing staff, and we hired for the personality type and for other skills that were lacking in our office to be the care coordinator. And our care coordinator works only 2 days a week. And as we get this program going that we have for self-management program for our patients, we will have her working more days a week, but that will be patient time. She'll actually be, talking face-to-face with patients, doing 1-hour sessions with patients. So when she starts doing that, she'll actually be in the office more days a week. But the administrative part, when we divided everything up, we decided that the administrative part that she would be the best at would only require a couple of days a week to be done, and then we have our MAs do all of the registry upkeep. They enter all the data. They do all the maintenance of the registry, and all that our care coordinator has to do is simply run the reports. She comes to the meetings to be sure that she helps problem solve any issues and to help be a cheerleader, so to speak, with the team. But that's how we divided it up. I think that one of the big messages here is that we all have to take into account our individual circumstances and figure out what will work in your office. That was a long answer.
Well, no, I appreciate it. Well, related to that, there's a couple of questions related to how the care coordinator and the practice administrator interact and sort of where their roles fall or how their roles are different.
The care coordinator and who?
And the practice administrator.
Oh, okay. Oh, yes, I am. Yes. So in the past, up until now, because our former care coordinator was not, she didn't have a lot of administrative skills. So up until that time, I did have to do the reporting and a lot of these administrative pieces. But the more that we got down the road, the more my job was getting bigger and bigger until I wasn't able to keep up with it all. And so when we made our wish list, that was why we put a lot of these things on the wish list, because we needed somebody to take over and run with this so that it didn't depend on me getting bogged down with, paying bills or doing other things that were financial impact on the office, doing the payroll and those types of things. So the way that we kind of divided it up was that I took all of the sites. I sat down with her the first day or two that she was there, and I gave her, I put the report software thing on her computer. I sent that to her so she could do that. I went in there to show her how to run it, and she had already figured it out. And she's becoming the PR person in this area. So I think that it has made it so that I can focus more on the financial aspects of the practice, and she's taking over more of the connection with all of these different entities and making sure that these programs get developed and run. So it's been a big relief to me, because I was getting swamped more and more as every day went by and feeling this has been a high priority to me. I actually, if you look at my personality type, I'm probably more suited to being involved in these issues than I am with the books, but I do that, and I do that okay, so, and that has to be done. So I think that it's an evolution, I guess I would say. Once you start down this path, you just kind of have to figure out how things are going to evolve and how to delegate, how to find people that fit the things that are needing the most help at that particular point in time.
Okay, thank you. And then I'm going to ask one more of these questions. It's sort of a couple of folks asked some similar questions. It's a two-part question. So can you describe how many patients, clinics, or providers are in your practice or that the care coordinator is supporting? And then the second question was how your program is funded. So you could do these two pieces, then we'll go on to the next section of your presentation. And I'll try to get back to some of the other questions as well if I can after we're done too.
Okay, great. Yes, we have, right now we have 3 providers. Back when we first became a patient-centered medical home, we only had 2, but we were looking for an MD, and we finally found one, and so now we have 2 MDs and a nurse practitioner. And our total number of staff members are 11, including the providers, and that's, of course, a couple of people are part-time, so it might be the equivalent of 9 full-time employees. And the funding, of course, because we're a level 3 patient-centered medical home, we are getting the monthly payments from, I think, about 6 different insurance companies. And so that has definitely made it easier financially to feel like we could make sure that we have the staff appropriate to meet all of these demands. We had gotten quite a ways down the road with only an MA as the care coordinator. So it can be done, but when we reached a certain point, we realized we weren't going to do anything more spectacular than we'd already done if we didn't get someone in there that could really move the ball. So that's when we made that transition. But back when we first became a patient-centered medical home, obviously we didn't have any income yet, and it was a while before that started coming in. So we were, being financially conservative, but at some point we had to make a change to really be able to be effective. So that's where the money comes from, to be able to pay for the care coordinator and to be able to pay for any additional hours that your staff might have to work to get everything done.
Great. Thank you, Judy. Why don't you go ahead with the rest of your presentation, and then we can try to get back to some other questions right after that.
Okay. So the next section is team building. And I would say I would be this strong about this statement, and that is that if you do not become an expert at building a team that will work well together, you will never get anything done, because there will be a lot of things that will come up and block your success. And so that's why this makes a really good combination with the care coordinator presentation, because the two things that are key in being successful is having a great person in the care coordinator role and having your team work well together. All of us know and understand that utilizing everyone on the team is the best way to solve problems and create plans. But if you do not understand the factors that can undermine functionality and success of a team, all your best attempts to create change will go nowhere. Nothing will change. The results will be the same. So that was another area that I started to study after we became a patient-centered medical home, and that is that a book, and probably a lot of you have seen this book and maybe even read it. It's called The 5 Dysfunctions of a Team by Patrick Lencioni, and this is the pyramid that he has in his book. And you start at the bottom and you work your way up. So the bottom category is the necessary foundation. You cannot go to step 2 unless step 1 exists, and so forth. Step 1 is the absence of trust. If you do not have a team that trusts each other, then you will not be able to go to the second level, which is conflict. You have to have a good, healthy conflict to be able to have a team that's going to work well together. And if you don't have conflict and you don't have trust, then you will not be able to have commitment from all of your team members. A lot of your staff will be resistant, and they'll sit on the sidelines, and they won't help. They'll watch and wait for you to fail. And then the 4th level is accountability, and if they have not committed, if every single person on the team has not committed, then you can't hold them accountable. So that one is dependent on the one before it. And then the last one is results. So if you have not held everyone accountable, you will not reach your ultimate goal of results. So the first dysfunction, we'll talk a little bit more about the absence of trust. As you can see, this little boy is helping the other boy over the fence, and takes trust to let someone else lift you up and help you to get over the fence. So that's extremely foundational to this whole program. So it's important to the facilitator. In our office, that's my role. I'm the practice manager, but if someone else is more suited to it, someone else can take that role. But I become the one who makes sure that no one in any of our staff meetings, when we're discussing issues, if their ideas are not put down or they're treated as an equal with anyone else. Doesn't matter whose role, who it is that's talking, whether it's the receptionist or the scheduler. What they say has to be treated with respect, and the same for everyone on the team. So here's what it looks like if you don't have a team that has trust. They will conceal their weaknesses. They'll hide their weaknesses. They'll hesitate to ask for help because they'll be embarrassed and they'll be afraid. They'll hesitate to provide constructive feedback, and they will dread meetings. So you want to make sure that anything that's contributed, that they are recognized in a positive way and made to feel like it was the benefit that they shared it. And then the second dysfunction, fear of conflict. As you can see, this woman is working on her computer and trying to talk on the phone, and this little girl is interrupting her, and she wants to just not ignore it by plugging her ears. So that happens in your staff meetings. People will be afraid to bring up a topic because they're afraid that there's going to be conflict and that people will be uncomfortable, and so they're afraid to bring it up. They'll ignore controversial topics that are critical to team success, or they'll fail to utilize input from all of the team members. And again, that results in boring meetings. So the third dysfunction is the lack of commitment. And this picture is supposed to indicate different levels of increasing commitment as they go further up the building on these different levels. So again, if you have not gone through the conflict stage, you do not have anybody committed to the plan. I'll tell you some personal experiences when we get to the end of this particular section that will make some of this more easier to remember. So if a team fails to commit, they have a lack of focus. It undermines the success, and it revisits discussions and decisions over and over again because they keep bringing them up to talk about them because they really aren't committed, and they're basically wanting to figure out how they can get out of it. And then dysfunction number 4 is avoidance of accountability. As you can see here, the measuring of calipers and rulers. You have to be able to, and this is one of the things that I think has changed the most since we became a patient-centered medical home, is that we are operating our business based on reports and actual facts. It's so easy to think that you're doing a great job in so many areas, and then when you run the reports, you find out that it's not so, and so you really have to practice based on those reports. And then people who are avoiding accountability, it creates resentment among team members because other people are trying to pull their weight and do their part, but they see people that are sitting by the side not doing anything and not helping. And then it encourages mediocrity, and they often will miss deadlines, and it places undue burden on the team leader as well. So the last one is the inattention to results, and this graph right here is an actual graph of our practice progress just in the last 6 months. That first part of the graph on supply and demand were the results that we reported back in June of 2010, and the purple is what we just reported this month. So our total number of patients increased about, I think it was 1,600, and the supply and demand, both went up significantly. So you have to be results-oriented. And the team that doesn't focus on results fails to grow or improve. They lose achievement-oriented employees because they want to be measured by results, but if other people are abusing it and not measuring up, then they feel like they need to find a place that's going to be more oriented to achievement. And then it encourages team members to focus on individual goals rather than on the team goals, because they get discouraged and they feel like, well, I have to focus on my own issues because I can't worry about this team. They're not pulling their weight, so I'll just do a good job myself, but forget about the team. So these are some examples that I put here to talk about of what has happened in our office when we applied these principles. The first one was our very first attempt right after I presented this information to our staff. We decided we were going to pick something really simple that wasn't going to be complicated, and we brought all of our staff together and decided we need to pick a time for our staff meeting. We'd had a lot of complaints about it being at lunchtime because the providers they don't like to be mentally changed from what their focus is with patients, and so and other people didn't like it as well. It was interrupting their middle of their day. So we had this staff meeting and we just hashed it out, and we talked about what would be the best time to have it. And they came up with 7:15 in the morning on a Monday morning, which totally shocked me. I never would have asked them to do that. And so they, but the surprise was that they made this decision, and the first one that we did, everybody showed up there. And we haven't had, actually, we haven't had a problem with attendance ever since that decision was made. So that's just a small example of how when everybody buys into it, and we did have some arguments about when was best and some different aspects, but that's what they decided, and they've lived up to it. I'm a little short on time, so let me jump to one that might be more interesting. The goal for signing up patients on NextGen, that's the third example there, we had in one of our staff meetings, we decided NextMD is actually our patient portal software, just so that you know. And we wanted to get as many people signed up for that program as we could. And so we talked about it, and we wanted the staff to make their own goal so that they would buy into that. And they did. They made their goal really low. And so we had, we wanted them to be accountable, so we went ahead and went with their goal. But they already are saying that they're ready to up the goal, because in the very first week they more than doubled what their goal was. And so it's definitely, I can testify to the fact that it's a much different picture when you have everybody working together as a team. So we'll look at this pyramid again, just to review the steps all on one slide. So first of all, you have to have that trust level. You have to make sure that everybody is heard. You have to be able to make sure that people feel comfortable to bring up arguments and conflict. One of the issues I forgot to mention with this decision on the goal was that our biller, she spoke up because she was in our meeting, and we were talking about, mostly it's the doctors and it's the MAs and the front desk that gets an opportunity to sign people up because they're the ones that see the patients. But the biller was there, and she said, well, I don't think that I'll be able to sign anybody up because they don't want to, when they're talking to me about their bill, they're not interested in talking about doing some other thing. They're going to be irritated if I bring it up. And so we argued that we thought everybody should have to at least sign up one person before they should be entitled to a reward for it. Well, she wanted to get the reward, but she didn't feel like she could possibly sign anybody up. So the other people in this team, they said, well, hey, sometimes we're way too busy when these patients are wanting to leave and we want to get them signed up. So if it's okay with you, we can send them to you and ask them and tell them that you would help them get signed up. And so she was thrilled about that. She said, oh, that's great. Then I'll feel more. She said, I'd rather sign people up and feel like I deserve the reward. So it's just fun to see how that all happens. So then the commitment comes from the fact that everybody agrees, and you argue it through until everybody agrees. You don't make a decision until you get at least commitment, even if it's not the ideal decision. But as long as everybody has committed to it, then you can hold them accountable. And you can run reports, and you can give them feedback so that they can see if they're meeting their goals, and then you will see results happen. So I found this book, to be an extremely valuable one, but there are lots of books out there on team building that you could read and get a lot of valuable, helpful information from. But I was a firm believer in teamwork before I read this book, but it helps to understand what can undermine it, because if you don't realize the things that can undermine success, then you will wonder why you're not making any progress with your team. And then, so the conclusion is create and support an atmosphere of trust at every opportunity. Help your staff engage in healthy conflict around ideas. This will result in commitment to decisions and plans of action. Then and only then will you be able to hold one another accountable for delivering against those plans. And the previous foundation will make it possible to focus on the achievement of collective results. So I'm sure that there are more questions now. These are the references, just the book, The 5 Dysfunctions of a Team, and that link right there will take you to their website, and they have a survey there that you can take with your staff if you would like to do so. You can have do the survey in your staff to see what areas you might need to focus on improving. So now let's open it up to questions.
Sure, Judy. I'm going to go back. I'm going to ask more questions queue up, and I'll go back to a couple of questions we didn't get to cover earlier. One of the questions was around the patient panel size for the care coordinator and how the patients are selected to be engaged with the care coordinator?
Okay, well, in our office, we're NCQA certified for diabetes and heart stroke, and so at this point in time, the patients that are in our registry are in those two categories. And so that's been our primary focus to start with, is to engage those patients in these programs because they have the most issues to work on, like their A1C, the ones that have their A1C over 9, or patients that have a blood pressure that's too high. So we take those reports that we turn into Health Teamworks every month, and we use those graphs to focus on the areas that they're not making much progress in. We started a group visit that is specifically the only one that we have started right now is for diabetes, and we do want to do one for heart stroke at some point. But our care coordinator, she did a survey of the patients that are in the diabetes registry and asked them what they would be the most interested in hearing if we had a guest speaker at our group visit, and found out that depression was very high on the list. And so these are the two categories that we focused on, but we're starting to do the depression screening, the PHQ-2 and the PHQ-9. We're finding that it's very closely related to the two conditions of diabetes and heart disease, that often that this is the reason why these patients aren't able to take control of these conditions, even when you give them all the tools that they can have. If they're struggling with depression, they're not able to do any of them. And so this next group visit that we have a guest speaker scheduled to speak on depression. We're trying to get more connections with counselors. We're actually to have an appointment this week to talk to a counselor about using our office space so that we can actually have our patients come back to our office to speak to a counselor. And so these are the three things, these are the three areas that we're focused on. And the patients in our registry, between the diabetes registry and the heart stroke registry, is only 170 patients right now.
Okay. Thank you, Judy. I'm just checking out questions. One related is there a full-time care coordination team to coordinate care all days, or is the coordination limited to the days when the care coordinator is present?
At this point in time, we only have her there those 2 days, but she is willing to be accessible through email all days of the week. And so if there was an urgent need, she is available, but basically she's in the office just Tuesdays and Thursdays. So it is kind of spread out through the week, fortunately. And like I said, she will increase those days as we get this self-management program started, where it's a series of 5 visits that patients will get enrolled in, and they will, the first one will be billed as an extension of the doctor's visit, and then the additional ones are billed as a separate visit. I think that the code allows you to charge, I think it's about $28 or something for a 1-hour visit. And so when that starts, she will be in the office at least an additional day. And, you know, as that program gets to be a bigger program and meets more and more needs-wise, it could be 2 days, additional days. But at this point, that's all that she's actually in the office.
And there was a question about the monthly payment you're getting, and I'm going to build on it a little bit. The question is it the same for all the insurance providers, and what would the basis for that rate? And then the question I'd like to build on it is actually, given that the project is somewhat time limited, what is your anticipation going forward after, if the project, if the payers do not continue to pay over the longer term?
Well, that is a good question, and I know a lot of practices are worried about that. What's going to happen if they stop funding the level 3 patient-centered medical home? And I have to say that you better spend your money wisely during this period of time, so that when the end of the pilot comes, you're in a financially strong position to be able to survive. I know this, that we would not turn back. We would not be able to function the way we functioned before. because it would just be so demoralizing after functioning at this high level and having bigger meaning, something bigger to live for. I mean, this has transformed the field of medicine from being caregivers to being change agents, and I have to say it's a lot more satisfying for providers. It's a lot more satisfying for the staff when they see these patients actually making progress. And so we would not be able to change our way of treating patients after this is over. But financially, if you don't, like in our case, we made sure that when that money came in that we were going to spend it wisely and make sure that it was that we would be in a good financial position for survival if that money were to go away. Not everybody has that option because in a lot of cases there's such a financial burden that they would not be able to make that successful in such a short period of time. So I'm not exactly sure how to answer that. I know that we have, if we had to survive on just what we bill insurance companies for when patients come in for their visit, it would be a very tight budget, and we would probably have to cut back a lot of staff, and there would be a lot of unhappy people. So I don't know what will happen. I actually have been just believing that this would go on, and financially we because of the decisions we've made, I mean, I think that you have to do what you have to do, whether it's invest in things that are going to bring you extra income to supplement what would happen if it went away, or if it's paying off bills so that you don't have debts that are out there. Whatever it is, you need to get yourself in a good financial position because you can't count on it being there forever. But I really think that these insurance companies are going to, I have to believe that they will recognize the change in the health of their patients and that this would be very valuable to them. So I'm not sure what will happen, but we're going down that road because it's a more satisfying way to do medicine.
Thanks, Judy. Okay, there are a few more questions coming in. It's about, I want to be sensitive to the time. We have about 9 minutes left, so I'm going to try to get through at least a couple more of these. So one of the questions I want to be sure to get to is what role or person in your practice helps the patient with transitions of care throughout the care continuum?
Say that again.
Which role or person, if it's the care coordinator or someone else in your practice, helps the patient with transitions of care throughout the care continuum?
Oh, okay. Yes, that is our care coordinator, and she does have a background in public health. She has a lot of people skills, and she's definitely connected to a lot of organizations. She's in the process right now because she just started the 1st of January, so she hasn't even been in our office for 2 full months yet. But she is already developing a list of contacts that she, like for instance with Secure Horizons, they have a case manager that came to our office and met with her and explained the whole program, and they've connected with each other. And Secure Horizons is our biggest over 65 plan, elderly plan. So she's in the process of building those connections. But yes, she would be the one who does that. And you're probably thinking with her there only 2 days a week, how will that work? We're still figuring out that as we go because of the newness of her position. But because of her willingness to be accessible through email on a daily basis, at least she's aware of things that might be urgent.
Great. Thank you, Judy. One quick thing that, could you advance your slide one more back to the links? Because there are a couple of folks that have mentioned they'd be interested in recording those links. Oh. And just as a reminder to everybody on the webinar, this webinar and the slides will be posted on the pcpcc.net website following the presentation. And then another question I want to be sure to get to is to ask if you could say just a little bit more about your self-management program, whether it's related to Kate Lorig's self-management program, like Healthier Living Colorado, or is it a different program?
Well, it's one that we kind of are creating ourselves. It's meant to be helping patients to create their care plan. The name of our plan that we came up with was Passport to Health, and it'll be a series of 5 visits and each one has a script that is created just special for that, and I can't tell you exactly. I looked at the whole program, like an overview of the whole program, but it's just a series of, with the first time they're in, to talk about the areas that they're not being successful in, helping them through interview, what do they call it, the motivational interviewing, to help them design their own care plan, but then to come back for 4 more visits to follow up and to make sure they're on track with their plans, and if not, how to redesign it, so figure out what's not working for them so that they can say, well, this one hasn't worked so far, so what is it that's blocking it, what are the barriers, and what is something that's going to work better with my particular program. So it gives them multiple opportunities to follow up on their plan, make sure they're on track, and if not, getting back on track. That's kind of the purpose of it, because we've discovered that it takes a lot more input than just seeing the doctor and having the doctor help them with a care plan. I look at myself. I mean, I've been wanting to lose 20 pounds for 20 years. And so you really have to have someone who is a successful person who can intervene. And to get you connected, there would be a time to get them connected with other programs like Healthier Living, like group visits, other programs that might work for them, joining a health spa, whatever it might be, but being a place where they can connect them to these resources.
Great. Thank you, Judy. And then there are 2 more questions I want to get to. I'm going to ask them both. They aren't really directly related to each other, but I'm going to see if you can try to touch on them both in the last few minutes we have. One is, does your clinical care teams engage in team huddles during the course of the day? And then the second question is related to outcomes. Have you experienced a significant reduction in ER admissions, inpatient admissions, et cetera, as a result of care coordination?
Well, on the topic of huddles, we do a huddle every day, and we do it the first thing in the morning. And everyone in the office is involved, including the providers. We have a format that we call a PIT format, PIT. We start out talking about patients that are on the schedule for that day. And during that time, we go through our hospital logs. We keep at the MA station where we record anyone who's been admitted to the hospital. We've been working with communications with hospitals. With most of them, we get the electronic record their report goes directly into our electronic record, into a PAQ, and the doctor has access, but we track whether they notify us about a patient by fax, by phone, because the patient called us and told us they were in the hospital and that nobody from the hospital told us. We keep track of that on a daily basis in our huddle. We also then, the I stands for internal appointments. We talk about those things so that everybody knows what to expect for the day. Like today, I told them I'd be out of the office for a period of time for this presentation. And then the T stands for task, and we just cover any issues that are presented that affect the staff, like if the computers or the printers or anything is causing a problem, or if there's some particular task that needs to be done that day and it requires any coordination. So we do that every morning. Some people do it at lunchtime and they reflect on the morning and then talk about the afternoon. Some people do it at any different times of day, but it works well for us. We had to adjust our time when the phones started ringing in our office, and we had to make it 8:30 for the phones to start ringing to give us quiet time to do our huddle. So the staff gets there at 8 o'clock, and then we huddle between about 8:15 to 8:20 or 25, and then we're ready to see that first patient at 8:30. So and then the second question that you asked, and I should be writing these down, but I wasn't.
That's okay. If this is just, and we have about 2 minutes left, just to, but I want to try to get a quick answer on it if we can. Have you experienced significant reduction in ER admissions, inpatient admissions, et cetera, as a result of care coordination?
Well, I believe that we have, but to be honest with you, I'm not sure that we have good numbers that can substantiate that. I know we've been getting reports from United Healthcare and a couple of other, or at least one other, insurance company on ER admissions, and that number has been extremely small, and I know that it used to be higher. but that is an area that I don't think that we have come up with a report that can give us data that would be really definitive on that.
Okay. Well, thank you. And we have about 1 minute till the hour, so I want to close out the webinar by saying thank you so much, Judy. This was very informative, and I appreciate the audience listening in and asking questions. I know I didn't get quite every single question. I will try to identify those questions we didn't get to and see if I can perhaps follow up with Judy and ask her to reach out and perhaps respond. Most of them, we did get to quite a few, though, so hopefully that won't be too overwhelming. But we'll try to get to everything that we can in the next few days after the webinar. Also, just as a reminder, the webinar will be posted to the pcpcc.net website, and the slides will be posted as well. So if you've missed any of this, then you can certainly go back and listen to that, or pull off the slides if you'd like to take a look. So with that, I want to say a big thanks to Judy. We really appreciate you taking the time to present and look forward to your case study and the practice transformation guide coming out later this month.
Well, thank you so much. I appreciate the invitation, and it was a pleasure, and the questions were all very pertinent. I'd be happy to answer anything that comes in later.
Great. Thanks so much, Judy. I really appreciate you taking the time. And thanks, everybody, for participating.